Thanks everyone for coming. This is a topic that a lot of people don't appreciate hearing much about, given its location and how we look at the colon. But it's really an extremely important problem. And what we're going to talk a little bit about tonight is the anatomy a little bit of the colon, what the risk factors are that lead to this disease, colon cancer, colorectal cancer, some of the signs and symptoms that people may have, and then the options of how we go about looking for this problem. This is the third most common cancer in the United States, and it's second only to, in women, breast and lung cancer, and in men, prostate and lung cancer. Regardless of that, it's actually the second leading cause of death related to cancers. So not only is it extremely common, but it's a very deadly type of cancer. I think you'll see there also that about 6% of us will develop colorectal cancer in our lifetime. That's a pretty alarming statistic. A little caveat to that is about 20% of women and 25% of men will have polyps, which are the precursors to colon cancer. We'll talk about that in more detail, just to put that stat in your head. A lot of patients have misconceptions about male-female prevalence of the disease. Quite honestly, it's pretty close. So the common story of the wife brings her husband in to me to get his colon cancer screening, but she doesn't think she needs it, or vice versa. Usually it's the other way around. No, both of you need it. Looking back a little bit, you can see about 150,000 people in 2006 were diagnosed, and it's going to be a lot more as time goes on, as the population swells, and our population is aging, as you all know. And 55,000 of those patients died of the disease. The colon is a large place. It starts in the anus, which is what separates the outside world from our intestinal tract, and it travels into the rectum, which is really just a reservoir for stool to allow us to hold stool to when we choose to evacuate. The sigmoid colon is usually quite loopy on the left side here. The descending colon is the upper left side, and then the transverse colon swings across and the right colon comes down. The cecum is the end, your appendix is here, and this is where the small bowel enters. So the colon's predominant function is to absorb water. It doesn't really function much in terms of absorption of nutrients. That's really the small bowel's job, which is north of the colon. So what are the risk factors? One is increasing age. Inflammatory bowel disease, there's really two major types of inflammatory bowel disease, and those are inflammatory diseases of the colon, and they markedly increase the risk of colorectal cancer. Family history, and that's not just of colon cancer, that's also of colon polyps, the precursor to colon cancer. So it's really important when we see a patient, we're going to ask you, what about your family? Brothers, sisters, kids, mom and dad, relatives. And first-degree relatives are far more of a risk than further removed relatives, second degree and onward. But the more relatives and the younger their age that we find it, the higher the risk to you. Diet plays a role for sure. High fat is always bad. Low fiber, there's some interesting studies in some tribes in Africa that basically eat roots and have virtually zero colon cancer. Whether that's completely nutritional or somewhat genetic, no one knows, but it certainly plays a role. Obesity is not good. Lack of exercise also plays in there. Alcohol and tobacco contribute. And then the genetic syndromes, and I just listed two here that are ones that we see rarely. These are very uncommon genetic syndromes. You're talking about less than 1% of the patients that develop colon cancer, but very important to know if patients have them because the risk is so high. So we talked a little bit about the causes, certainly genetics and lifestyle factors we talked about. The exact cause we're not sure. We're getting better as the Human Genome Project is getting further and further along. We are finding specific genes that are predisposing to this condition, and that's lending itself to a lot of research. And I suspect in the future a lot of medicine will be genetic based. Can occur anywhere in the large intestine. It almost always begins as an abnormal tissue growth called a polyp. And this is one example of a polyp. The normal colon is surrounding this, and we're looking through a colonoscope here into the bowel, and that's the lumen, that's where you're going. And this is a stalk and a growth on that stalk like a mushroom. That's what we call a pedunculated polyp. Some polyps are flat against the wall. This one happens to be pedunculated. But polyps really are precancer. There's different types of polyps. So when we take out a polyp, and that's what we do, we take them out to try to prevent this whole sequence. We'll go into that in just a minute. But we send that tissue to the pathologist, and depending upon the type of polyp, the location in the colon, and the size of the polyp and the number of the polyps, we can really get a sense of the person's risk for getting more polyps. And this, I think, is really the linchpin of the whole discussion, because what this really tells you is you can find people with these polyps and you can prevent colon cancer completely by taking them out. What this really is an opportunity to screen people to prevent cancer. It can take probably 0 to 5 years for polyps to turn cancerous, but probably more like 0 to 10 years to go from normal colon tissue to cancer. So normal to polyp to cancer. So the longer a polyp sits in your colon, the more likely it's going to degenerate into a cancer. The big issue with cancer is that the earlier we pick this up, the better off people are, because once that cancer gets going, it spreads. So it's the first thing it's going to do is get into the wall of the colon. The second move is into the lymph nodes, and then from there it spreads out through the body, liver, etc., abdominal cavity. Again, removing them is the key here. Signs and symptoms of colon cancer, I think the biggest point here is in green there, and that is that most patients don't have any signs or symptoms. The first question I often ask is, what brings you in? And often, our 56-year-old man will say, the wife made me come in. I feel fine. I feel absolutely fine. I don't know why she made me do this. And the answer is because she's right. Because most people don't have any symptoms. And by the time you do have symptoms, usually it's too late. So this is something that you don't really think about because, I don't feel right. You do it just because you should get screened. And we'll talk about when we start screening, etc. Things that we look for are change in bowel habits, so diarrhea, constipation, alternating constipation and diarrhea in some people. People that complain of incomplete evacuation, they don't feel like they evacuate the bowel well. Thinner caliber, which means thinner diameter, so my stools used to be this thick, now they're that thick. Blood in the stool, certainly mucus in the stool. Abdominal discomfort, gas, bloating, pain, cramping. We don't like weight loss as physicians. We generally think of bad things when people complain of weight loss unless they meant to do it. Decreased appetite, fatigue, anemia on your blood testing. Those all may be bad signs. Okay, so how do we screen? Basically, the key here again, and I think I brought this up, is that the polyps are the precursor. The earlier we find it, the more likely we are to help people, and removing polyps can prevent it altogether. But if we do find a cancer, the earlier we get it, the better off you are. And you can see here about 90% of people, if you catch it early, do absolutely fine. They have to go through some certain treatments, often surgery. The more advanced it becomes, the prognosis drops rapidly. And the concern here is that probably fewer than 50% of people actually do we find it early. And I think that speaks probably more to the fact that people are not getting screened. Okay, that's really a statistic saying we're not doing as good a job getting you guys in to do these things. When do you start? The key here is that about 90% of people with colon cancer are age 50 or older. But interestingly, colon polyps and cancer incidence rises exponentially at the age of 40. So when we hit 40, something changes and the risk factor rises rapidly. But we don't really think in an average risk person, which means you don't have any risk factors, no family history, you don't have inflammatory bowel disease, you don't have any genetic syndromes, there's no family history, you don't have any signs or symptoms, you just came in because you're age 50. That is when we generally start people. Once you start talking about risk factors, we may increase the frequency of how often we look at your colon. We may start you at a younger age, and those are all determined by the number of risk factors. There is some data that came out interestingly recently, and a lot of the societies now are saying that black patients should be started younger. For some reason, black patients tend to form polyps at a younger age and more advanced polyps. So we are starting them at age 40 to 45. And there's some data now about American Indians or Native Indians, or Native Americans, I should say, starting them early also. So there is some genetics there. And then anyone with signs or symptoms, blood in their stool, mucus in their stool, reasonable to screen them at that point, period, regardless of their age. Again, the bottom there just kind of reinforcing the fact that we're not doing a great job. So about 60% of people get screened in their lifetime. And now that actually, as dismal as that sounds to me, that actually is better than what it used to be. We used to be down in the 40% range before Medicare said, look, this is a good test to screen people, that namely being colonoscopy. So we're actually doing better, but that's still not a great statistic if you think about it. All right, so how do you screen someone? So there's a bunch of options out there, and I'll go through some of these just so you guys have some understanding of the positives and negatives of each one, because no test is really perfect, and the goal in cancer screening in general is to have a test that's relatively easy to do, extremely accurate, and preferably one that not only can find it but treat it while you're there. Okay, that's really what you're looking for. And then there's just acceptability to patients, right? You want people to not say, I'm not doing it. Just starting with the first there, this fecal occult blood testing, probably the oldest way that we screen for colon cancer. And the guaiac-based was really the original. And the concept is that if you have colon cancer, it's more likely that you're going to have blood in your stool. Problem with the guaiac-based testing, though, is it's not specific to human blood. So if you eat red meat and you get your guaiac test, you could have a positive just because you ate red meat. So what we found with the guaiac is that it had a lot of false positives. So it was positive, but it wasn't really positive. And it's not a standalone test, any of these fecal tests. So if you do get a positive, you got to do a colonoscopy to look into why it's positive. So it's purely diagnostic. The FIT-based stool testing has come out more recently. This is fecal immunohistochemical testing. What this is able to do is determine between human and non-human blood. Turns out that it's much more specific for colon cancer than the guaiac-based. It's more sensitive, which means it picks up more colon cancer, but it's still far from perfect. Stool DNA testing came out much more recently, and this is really pretty cool stuff. This is getting again towards the genetics of medicine. As we're starting to learn more about the genetics of disease, we're starting to learn that we can look for specific genes or DNA in stool and see if people might have a higher likelihood of colon cancer. Flexible sigmoidoscopy is probably the age-old test. This was a test that every doc pretty much did in their office, primary docs, GI docs, etc. And it was a quick look. That's basically no longer being done. Colonoscopy I'm going to come back to because that's what I'm going to talk to you about. Barium enema, that's cruel and unusual punishment. We rarely do it anymore. CT colonography, this is still a relatively exciting technology. The concept here is that can we pick up colon cancers by doing a CAT scan, by doing a less invasive test? So can we somehow do better than these fecal occult tests and a sigmoidoscopy, but get an accurate study without being invasive? The problem is, number one, and this is getting more and more concerning, is that it's radiation exposure. So there's a big concern about radiation exposure. It also is completely diagnostic. So if you find something, you still got to do a colonoscopy. In almost all cases, you still have to do a preparation, which we'll come back to, which means you got to flush out the bowel. So it's still not approved. The data still is showing that it's not near as good as colonoscopy, which is our gold standard. And it can be uncomfortable, and it's not without risk, and it's purely diagnostic. So it's not perfect. The capsules are really exciting. This is still in research. It's not been approved yet, but the capsules predominantly right now are being used for the small bowel. So basically what this is a pill capsule with a camera in it. And that pill tumbles through your bowel and takes pictures. So you basically get a video. It's really neat stuff, right? Problem is, again, purely diagnostic. Currently, this may change, but currently you can't stop the thing. So as it tumbles by and you might see something, you can't say, okay, stop there, let me look at this more carefully. Just off it goes. Being researched or getting better, not as good as colonoscopy. Still got to take a prep for it because you got to clean out the colon so you can see, right? Maybe in the future this is going to be a big one. We'll see. And now there's also a blood test that's coming out, and this is really just getting at the very beginnings of genetics in colon cancer, which is you're looking for genetic changes that may show that you have a genetic switch that may increase your risk of colon cancer. Right now, the sensitivity or the ability of it to pick up colon cancer stinks, about 40%. But it's exciting. If we get better at this, maybe we could start doing blood tests and have a sense of who's higher risk than someone else. Colonoscopy. This is really the gold standard because still it is the best test. So what colonoscopy allows us to do is to look at the entire colon with a tube, and it allows us not only to look but to treat. So if we do find a polyp, we can actually remove it right then and there. So it's both diagnostic and therapeutic. The disadvantage of colonoscopy is that you do have to take a prep. We'll talk about that in a second. We need you to flush out or else we can't see well, right? We've got to get rid of stool. And it's not without a risk, but those risks can be serious. And the big one is what's called a perforation. So if we puncture the intestine with a scope, it can result in surgery. It's about a 1 in 1,000. Data now is coming out maybe more like 0.5 in 1,000. It's really rare. With everything we do, there's a risk benefit. But the reason we do a lot of these is because it is so good and so effective, and quite honestly, it is very safe. This is just an example of what the bowel looks like when it's clean. This is in the transverse colon. The folds are kind of triangular, but this is a fold. This is a little bit of stool left over. These are blood vessels running in here, okay? And that's a very nicely prepped colon. You can see that we can really see the details, right? So if there were a polyp, we'd have a very good chance of finding it. And the key to colonoscopy, and it's getting more and more clear now, no pun on words, is that the prep is crucial. And the prep is crucial because if you don't do a good job, we can't do a good job. And if there's these subtle polyps, these flat polyps, we can miss them, right? No test is perfect. So part of this is patient dependent, and we are very aggressive in getting patients to do a good job with their prep, because if you're going to do this, we want you to do it well and not do it a lot. Okay, so the bowel prep, the whole concept of is to clean out the colon from the stool and give us a high quality exam and allow us to safely look and remove things. Usually we have patients consume it the evening before. The preps are changing. There are different forms now. It's not all the old route, which was a gallon of fluid. Now we're getting down to 2-liter size preps, often mixed with some pills or some other substances to try to get the same efficacy with less amount, less volume that you need to take. There are some dietary restrictions. We generally want people on clear liquids the day before. That means that it is a liquid and you can see through it. It is clear. We want you without anything after midnight, the night before the test. We give instructions on the details of when to take it and what type of prep from the office. We generally ask that people take the day off, the day of the procedure. You take the prep in the evening, so you can work the day before. Side effects are really uncommon. Some people get a little nauseous with it. Some people get chilled with it. Some people get crampy with it. And not surprisingly, everybody should get diarrhea with it, because if they don't, they're not doing a good job. High volume solutions, we mentioned, that's the old way. Problem is nobody wanted to do it. So what happened was you had these perfect preps and those rare people that took it, and you had not so great preps because most people kind of petered out by the 3rd liter. So these lower volumes are getting, again, at finding ways to get people to drink less. And we're getting pretty darn effective with it. When you come to Margaretville to get your procedure, you'll be admitted, so you're going to have someone drive you. We're going to put an IV into your arm. That's how we give you anesthesia. Reason to give you anesthesia, unlike the flexible sigmoidoscopy where people used to moan and groan, is we don't want you to be uncomfortable. And more importantly, it increases the yield of the test, because if you're comfortable, we do a better job. Okay? And we can take our time about what we're doing. The anesthesia that we use this day and age is different than what we used to use 10, 15 years ago. It's actually propofol. It's administered by an anesthesiologist, so it's very, very safe. Very well tolerated, virtually no side effects. Procedure itself depends, probably 15, 20 minutes, sometimes a little bit longer if we find a lot of polyps or if it's a tough colon. Generally a short procedure. So then we recover you, IV comes out, off you go home. We generally want you on a relatively bland diet that day. And sometimes I put some restrictions on what people do if I take out a lot of polyps. So the scope, the goal of it, again, is we're not just looking at the anus, rectum, and sigmoid. We're going to try to get all the way. Okay, and sometimes we even get into the small bowel a little bit. So we try to get a complete exam. Here's another example of a polyp. We have devices that we can pass through the scope. This is a snare, and basically like a lasso traps the polyp. We cauterize the base, allowing us to remove it. So what should you do? Well, first of all, if you're 50 or older, talk to us, get screened, call my office. Try to be physically active, maintain a healthy weight, eat a healthy diet, lots of fruits and veggies, grains, cereals if you can. Not a bad idea to take a multivitamin. Folic acid, folate or folic acid, selenium may decrease risk of colon cancer. Antioxidants we're questioning too, like vitamin E. Limit the alcohol consumption. Don't smoke for many reasons. Calcium supplements have been shown to be effective to decrease polyp and colon cancer. They're probably better for people with a history of colon cancer or genetic syndromes like we talked about than for your average person, but not a bad idea. Aspirin, anti-inflammatories like Motrin, Advil, very effective actually, and data coming out more and more about them for people with polyp syndromes, history of colon cancer. But the problem is, and the reason that we don't recommend this, I make that clear, we don't recommend this to most, your average person, is because they also have risks like stomach ulcers and bleeding ulcers. So that's not one that we're ready to recommend, but in some selected instances we're doing that. And again, know your risks. If there's family histories, signs, symptoms, sooner is better. Questions?
The virtual colonoscopy, do you know anything about that?
That is the CT colonography. They're promoting that because it's a non-invasive test. It has not been approved to date for colon cancer screening, and it won't be paid for you by your insurance at this point. But that may change, as I said. It is a neat concept, but it's really, honestly, it's not ready for prime time yet. Yeah?
Is there any point other than psychological in people who get colonics?
I'm really opposed to colonics, actually. The data is really that it's not a good idea. There actually are nutrients in your stool that keep the colon mucosa healthy. Your colon wasn't meant to be a clean place. It's not what it's designed to do. And there's actually very good studies in people that you divert the fecal stream. So let's say you had a colon cancer, we needed to take the colon, pull it out to the outside world, and we dropped down what was left. The segment that is not seeing stool gets inflamed. I'm not opposed to alternative remedies, I really am not, but that's one I don't like. I don't think it's sound. Yeah.
You said that 50 years or older should begin, but how frequently?
It depends upon what we find. So if you just come to me and you're age 50, you have no risk factors, we went through risk factors, you have no signs or symptoms, you feel great, I put the scope in, we get a good exam, you did a good job of the prep, I get all the way through, I'm comfortable that I did a good job, 10 years. If we find polyps, it's going to be less than that. The more polyps we find, the more aggressive the polyps, the larger the polyps, that interval is going to shrink. And then when there's risk factors, you never get out to 10 years. It's very dependent upon what we find and the details of what you come with. Yeah.
I heard in reference to colon cancer, by using certain types of light, they're able to determine takes, I guess, the guesswork out of is that a cancer cell?
This is really exciting technology. What we're working on, what we're researching and looking into is if we, instead of looking at the colon with just white light, regular light, what happens if we shifted it and looked with ultraviolet light? What happens if we stain the colon and then look at it a little differently with a stain? It's pretty exciting because I think what we're eventually going to have is a better chance of finding some of these subtle polyps. So the answer to the question is yes, we are starting to do that, and it's very exciting. And actually, we're going to have new scopes here within a matter of weeks, I hope, that actually have that technology now. We're doing procedures here in Margaretville now 3 times a month, 2 Wednesdays and 1 Monday now, full day. So the idea is obviously closer to home for people, easier to get your ride to bring you so you don't have to drive as far. And in addition to that, we now have high definition scopes coming, the top of the line scopes. So the technology that we're using is equivalent, if not better, than what Kingston has right now. And everything else basically is the same, which is the anesthesiologists are the group from Kingston, so you'll have the same people. Very, very skilled anesthesiologists with a lot of experience, do a lot of these procedures. And it's really just, it's a nice facility, I think. Our nurses are wonderful. We've been working a long time together. We have a really top-notch team for everything from when you walk in and are admitted to the procedure itself and the nurses in the room with us, to your discharge, as well as the people that help us to clean the scopes and the ancillary personnel. So it's really been great. We are really at a high standard right now, so I'm very, very pleased. Okay. Well, thanks, everyone. Hope that was informative.